Hi, my name is Rachel Dorland-Roan. I'm a registered dietitian nutritionist at IHS Growth Service Unit. As a dedicated scholar practitioner, I have chosen my educational path based on the needs and practice gaps identified in my community. I am very passionate about patient-centered team-based care and outreach, which leads me to be very active in my community at many levels with a commitment to developing and maintaining community partnerships that enhance health and well-being and community growth. I believe when communities come together, they can truly wrap services around community members to foster resiliency, incite culture change, and raise the standards for health equity by effectively engaging, enabling, and empower individuals to be their own health advocates and leaders within their healthcare teams. Today, I will present Integrated Patient-Centered Diabetes Care, a shared vision. I will discuss ways in which to optimize diabetes management within the patient-centered medical home model to engage, enable, and empower our patients. Diabetes imposes a substantial burden on society in the form of higher medical costs, lost productivity, premature mortality, and intangible costs in the form of reduced quality of life. The cost of the care for diabetes in the United States now accounts for 1 in 4 healthcare dollars spent in the U.S. After adjusting for inflation, economic costs of diabetes increased by approximately 26% over the last decade due to the increased prevalence of diabetes and the increased cost per person with diabetes. Care for a person with diabetes now costs on average about $16,752 per year. It is estimated that there are approximately 34.2 million people living with diabetes in the U.S. today, with numbers easily reaching 55 million by 2030. As practitioners, we must hone our root cause analysis skills and connect individuals with the resources they need, as we know many factors play a role in diabetes-related health. For instance, did you know the odds of an emergency room department visit or hospitalization were increased more than 5-fold for individuals with housing insecurity? We must consider factors of economic stability, social context, physical environments, access to healthcare, food, and education. Diabetes care in the U.S. consistently has failed to meet recommended quality standards. Collected data reveals significant quality gaps in the treatment of diabetes and in screening for diabetes-related complications. Nearly 1 in 5 diabetics has poor glycemic control, more than 1/3 have elevated blood pressure, and more than half of diabetic patients have an elevated LDL cholesterol level. Diabetics also do not receive appropriate screening measures. Only 28% receive the recommended HbA1c measurements more than once yearly. 55% obtain annual foot examinations, and 63% of patients receive an annual dilated eye examination. Outpatient care for diabetes exemplifies the challenges of and the opportunities for chronic disease management involving patients in their own care, particularly with regard to education and self-management, which can improve health outcomes as well as the diabetic patient's quality of life. However, the quality gaps that persist in the treatment and secondary prevention screening process demonstrate that pressing need to improve the adherence to standards of health care in both of these areas, especially as we move closer to value-based care and reimbursement models. The huge gap, ideal and actual diabetes care, is not surprising. Diabetes management is complex. Healthcare systems are more acute care oriented, not well equipped to meet the needs of chronic disease management, which requires a focus on self-management, support, patient engagement, team-based care, and population management. A critical component of patient-centered medical home practice is that members of a well-tuned healthcare team work together through effective coordination and communication to cultivate and promote a culture of teamwork, which leads to improvements in patient-centered care, including diabetes care. The delivery of evidence-based care is safe, easily accessible, and affordable, with each patient having a personal physician or provider who guides the team to ensure that care is coordinated across specialties and providers. The team as a whole has a whole person orientation with attention to not only medical but also psychological and social needs. The patient-centered medical home is looked upon by health delivery systems as a continuous quality improvement journey, as it is ever-changing to meet the needs of our patients. Our diabetes programming has been developed based on the PCMH model to serve our patients at every level. Now we have to work together to engage our patients to maximize utilization of the available tools through meaningful connections and referrals so they can become empowered to become the driver in the healthcare team. As practitioners of diabetes care, it is important to remember that the patient is the most important member of their healthcare team. After all, they are the one who is affected by diabetes and cares for it every day. Only they know how they feel and what they are willing to be able to do. They do the exercise, they make and eat the foods on their meal plan, they take the medication or inject the insulin, they check their blood sugar levels and keep track of the results, and of course they are the first to notice any problems. We as the healthcare team need to depend on patients to talk to us honestly and tell us how they feel and what they need from us. This will allow us to individualize care, not only to truly engage the patient in self-management, but to connect them to the resources they need, or that enablement piece to achieve the highest level possible of health and well-being, or that empowerment piece, with this level of care, our patients become their own healthcare advocate. They become invested in health and well-being and encourage others to do the same. Just one moment. Oh, sorry, I had an interruption. I didn't get that. There's 3 phases of diabetes care. Pre-planning for diabetes visits helps ensure that both patients and practice staff are prepared for diabetes visits. Ideally, pre-visit preparation starts at the end of the current visit. Patients schedule appointments for the next visit, which, if not at goal, may be in 3 months, and arrangements are made for A1C labs to be drawn just prior to the next visit or at the point of care, along with other labs, to ensure an opportunity for timely treatment adjustments. This way, the provider and patient have all the relevant information at hand to review, discuss, and adjust therapies at face-to-face visits. Compared with trying to coordinate a time to review the lab results a few days later, this approach saves time and allows for better communication between patient and provider. The process of pre-visit preparation involves the following steps. Proactively identify patients who are due for diabetes visits, contact patients with clear instructions, prepare patients to be active participants in their diabetes visits, use standardized written counter forms to organize information prior to the visit, and integrate strategies for relaying information to practice team members prior to patient encounters. Here we're implementing that PCMH model, and so we have team huddles in the mornings. The diabetes visit should be guided by the physician, making sure that the patient's concerns and needs are addressed and relevant clinical and behavioral data are obtained. Warm handoffs can be utilized during the visit to meet patients' individualized needs, move patients along the stages of change, increase patient resources and support network, and enhance value-added care. Warm handoffs can be planned during the team huddles or can be initiated based on the needs of the patient identified during the visit. And these are just short step-ins. You can provide minimal education, but you can use this opportunity to schedule a patient, and if they're not ready to be scheduled for nutrition therapy or diabetes self-management education appointment or clinical pharmacy, then what we do is ask, can we touch base with you next time you're in the clinic? And sometimes that really helps people move along. Sometimes they're not wanting to make that appointment, but you can definitely say, oh, can I check back with you next time? Do you have any questions today? And then the next time you check in, maybe they'll be ready to make that appointment. So it is important to develop a system for the end of the patient encounter that supports careful review of the after-visit summary to ensure that patients understand and can execute their care plans and goals, including a plan to order labs just prior to their next visit. This review should be supplemented with patient education materials and referrals to community resources, as well as referrals to specialists as appropriate, to aid patients in their diabetes self-management and support at recommended intervals. It is particularly important that patients leave the office with a clear understanding of medication management, especially for newly diagnosed patients and those with medication or therapy adjustments. Patient engagement. Engaging patients as active participants in their disease management decisions is an important method to encourage adoption of and adherence to treatment recommendations that align with their patients' needs and preferences. Evidence-based patient-centered approaches to facilitating engagement include shared decision-making, motivational interviewing, and goal setting. Each of these approaches or techniques addresses a unique aspect of patient engagement and disease management support during the diabetes visit and can be applied to pre- and post-visit communication as well. Central to all is the importance of collaboration between patients and the healthcare professionals to negotiate diabetes-related decisions. In the context of diabetes care, a sound shared decision-making approach first requires that healthcare professionals be informed of current treatment recommendations and that patients receive guidance when choosing treatment options. It is important for all diabetes care members to be on the same page so patients are receiving consistent messaging throughout their visit. A motivational interviewing style of communication can be incorporated into routine patient care. It has been applied to diabetes to encourage patients to discuss behaviors associated with self-management, as well as to assist patients in their motivation and confidence for making changes that will improve their diabetes control. Goal setting is a valuable strategy for improving self-management skills among patients with diabetes. The American Diabetes Association, ADA, the American Association of Diabetes Educators, strongly advocate for goal setting as an effective means to support self-care behaviors related to diabetes. Self-care behaviors includes healthy eating, being active, monitoring, taking medications, sleep health, stress management, problem solving, and reducing risks and healthy coping. Diabetes care team members play an important role in understanding patients' motivations to change, helping them set achievable and measurable behavioral goals and building them through barriers, guiding them through barriers and challenges that may come in the way of meeting their goals. So, patients may not meet treatment goals for a variety of reasons. What's important from a primary care perspective is to seek continued engagement with the patient population management, which can serve as a valuable resource for systematically identifying patients who are poorly controlled and bring attention to patterns of control, assuming they are in for routine or somewhat routine visits and have their lab work done. Proactively contacting patients provides the opportunity to encourage patients to schedule a visit with the appropriate clinician to reassess a treatment regimen and identify other factors that may be interfering with or negatively influencing a patient's ability to meet their treatment goals. Such factors may include changes in income or insurance coverage, increases in diabetes-related distress, depression, other health conditions, or competing demands. We often see that with our patients, that they have competing demands. So validated assessment tools can help identify and assess changes in these factors, including diabetes-related distress, self-efficacy, self-care activities, and medication-taking behaviors. Once identified, the healthcare team can then work with patients to address the barriers, either directly or through referral to other medical or community resources. Other practitioners such as pharmacists, podiatrists, optometrists, dentists, Mental health practitioners and counselors can have a significant impact on diabetes management and should be considered as important partners to the primary care team. Developing strategies for facilitating coordination of care with non-traditional practitioners and partners can help ensure a comprehensive approach to supporting patients in their diabetes management. Patient navigators, care managers, and care coordinators may serve as useful resources for linking patients to appropriate healthcare providers. The way our practice coordinates services with our practitioners will depend on the availability of our local resources. So, as we know, patients live, work, and play in a social and physical environments outside the healthcare system. They actually only spend about 2 to 10% of their time in a medical facility, and that's even less now that we're in the middle of COVID. Therefore, clinic-community partnerships are key to building community support for diabetes self-management, increasing patient access to effective community resources through linkages with relevant agencies and organizations is a cost-effective way to obtain important services such as nutrition counseling or peer support groups. Furthermore, clinic-community partnerships have demonstrated benefits at the individual, organizational, and community levels. Our Diabetes Center of Excellence team continues to work diligently to build and maximize such partnerships and is effectively creating the bridges to community services to wrap services around our patients to enhance patient-centered care. We need to be making the resources readily accessible to patients. It is important to not just hand patients a list of resources. We need to work with the health system within the health system to coordinate planning and referrals. We must strive to link patients to community resources by developing roles of community support specialists and or patient navigators. These are roles that we're currently developing here at our service unit. It is important to develop supportive programs and policies within community organizations so they can contact patients and know how to refer back to the health system when problems are identified. Ensure that you formalize said policies so that they can be reviewed and updated annually and survive any staff turnover. So to achieve community culture change, it is important to fully assess your community to understand the impact of the following on one's health and well-being. So active living, clinical and community linkages, foundational skills and practice, health equity, healthy eating, health and safe physical environments, schools, social and emotional wellness, target populations and settings, tobacco-free living, workplace and health, resources, and policy. So you must be able to also identify the key stakeholders to make change possible and to prioritize areas. I believe community culture change can start within our organizations and then grow out. And so recently we've been awarded the SDPI grant, and we're starting with clinical practice and then expanding out from there. And so we've been meeting with many community partners, and that our biggest partners so far are the schools, the Boys and Girls Club. We're going to start the trail program with them. We're going to be doing shared medical appointments, but we're going to be doing them outside of our facility to facilitate change. And so we'll have behavioral health and our diabetes team there. But we have been really well received by our communities. We're going to be starting with the curriculum stuff with the school. We've been invited to do virtual education for the kids at home. And so it's just really exciting and looking at how you can really change that culture within the community with those community resources. So individual resilience involves behaviors, thoughts, and actions that promote personal well-being and mental health. People can develop the ability to withstand, adapt to, and recover from stress and adversity and maintain or return to a state of mental health and well-being by using effective coping skills. Community health resilience is the ability of the community to use its assets to strengthen public health and healthcare systems and to improve the community's physical, behavioral, and social health to withstand, adapt to, and recover from adversity. Why is resiliency important for diabetic patients? Studies in people with diabetes have shown that high levels of resiliency are related to lower A1C levels, indicating better glycemic control. Some people are lucky enough to be born with a high level of resilience, but even if they are not, one of them, they can boost their resilience by making connections with, by maintaining good relationships with close family members and friends, accept their support, and offer it in return. Accepting that change is a part of life, so accepting circumstances that can be changed, not instead of focusing on circumstances that they can't alter. Taking decisive action. When there are situations you can change, take action. Don't detach from problems and just wish they'd go away. Keeping things in perspective. So even when facing difficult events, try to consider the situation in a broader context and keep a long-term perspective. Avoid blowing small things out of proportion. Maintaining hopeful outlooks. This is done by cultivating an optimistic outlook and expect that good things will happen in your life. Try visualizing what you want rather than worrying about what you fear. Taking care of themselves, so, sorry, exercise. So exercising regularly and eating a healthy diet, meditate or joining community faith-based organizations, engaging in activities that they enjoy and that they find relaxing really helps people better to be able to cope with challenges when they are mentally and physically strong. So throughout our program planning, we weave in activities to develop a more resilient mindset and participants in resiliency building skills. Recently, we've engaged the community resiliency model education, and so we have some trainers right here, or educators right here at the service unit, and we have started offering those in our community. We've provided 2 so far, and they've been really good. And so our focus right now is training other healthcare entities or anyone that's really serving our community, and we'll also be able to offer the mental health first aid, and so where people can, it helps individuals recognize and help de-escalate situations and get people to where they need to be. So this resiliency, I think, is really important. It gives people the strength to know, even though they may be facing some challenges with diabetes and treatment and within their personal life, that it's something they can get through. And so that thankful, grateful attitude is really important to promote. So a successful diabetes program contains the following elements: diabetes support groups, basic diabetes education, comprehensive diabetes education and treatment, and diabetes prevention programming. The diabetes support group is currently being developed here at our service unit and can be utilized by patients that are meeting goals and or not meeting goals. I would love to see all of our diabetic patients coming in for diabetic checks and diabetes-related appointments to be referred to the support group to connect with their peers and to enhance problem solving around diabetes management. While we're developing here, I have done them in my community before. They were very well received, and it was amazing what that peer support, how that impacted outlook and really helped people identify that, hey, I'm not alone in this. I'm not the only one that's going through this. And so we did them once a month, and that seemed to work out when you're planning them. I had offered them for diabetic patients and diabetic caregivers. It's important to note that At some stages, it might have been better to separate the diabetic patients versus their caregivers so they could feel more free to talk. And so in developing our program, I'll certainly have that in the back of my mind. We are currently exploring the Living Well with Diabetes program for our basic education component that can be tailored to meet our community needs. Our program here at the Crow Service Unit includes medical nutrition therapy, diabetes self-management education, training and support, clinical pharmacy, shared medical appointments, intensive behavioral therapy for obesity, preventive health and wellness care, complex chronic care management, basic diabetes education programming, and diabetes prevention programming. These education and preventative health and wellness care services are being fully developed to guide patients through any and all of their lifestyle changes needs to improve an overall health and well-being. Services include tailored prevention and treatment advice, physical activity guidance, stress management education, building problem solving and coping skills, and sleep health recommendations. For patients with type 1 or type 2 diabetes, we are equipped to provide individual appointments and group education support sessions to provide patients with the right information, tools, and support needed to manage their diabetes. The mission of the CSU's Diabetes Center of Excellence is to provide comprehensive evidence-based diabetes self-management education to our patients and community. We are committed to the development of individualized patient education plans created jointly by our patients, healthcare providers, and educational staff to improve overall health outcomes. We strive to encourage our patients in self-care management by equipping them with the knowledge and community resources to maintain optimal diabetes control and to reduce risk of complications from diabetes. Lastly, we are currently developing our diabetes prevention programming as it is a vital piece to incite culture change in our community around healthy lifestyle habits. It is important for your team to come together and decide how patients are diagnosed with prediabetes and how we can maximize referrals to the program. That is one of the challenges I faced previously, is how we diagnose them, and so getting your whole team on the same page for that is really great. I suggest if you're just starting the prevention program, the diabetes prevention, so the DPP program through the CDC, I think a great run-through can be accomplished with your staff. So if you have a large staff, to have that be your practice. So I found that it did really a number of things. It helped us practice and model those healthier behaviors. It also helped individuals have more meaningful conversations around diabetes prevention, and diabetes prevention measures often are measures that we take when we're preventing diabetes complications. And so I just thought the programming was really well received by staff and really gave them some confidence in that word of mouth recommendation to then take the sessions was a big thing too. And so I recommend, if you're starting with a diabetes prevention program, if you have enough staff to really incorporate that. Another piece that went along with that here in Montana, where we have 2 activity days that kind of go in with that. And so it was great. We started a walking program that was staff-led, and then community members were invited to join in on those walks. And sometimes they were providers, and so walk and talk with a provider. There were many different gimmicky type things to bring that in. Here at CSU, we are really blessed with a great walking path around our facility. And so one of the things I'm doing with the SDPI grant is purchasing some adult activity equipment that will stage around the walking path to really engage patients with their physical activity. So it's important to not only assess your facility's needs and resources, but to dive deep into community resources to identify program gaps, maximize stakeholder reach, enable community partners to share knowledge, pool resources, access funding options, and encourage policy change to develop sustainable diabetes prevention and treatment programming within our service areas. So things you want to assess. So how many pre-diabetic and diabetic patients does your clinic currently see? And how are these pre-diabetic patients identified and diagnosed? What does your integrated care team look like? Do you have behavioral health, pharmacy, patient resource coordinator, dietitian, diabetes educator, and how many providers, nurses, and medical assistants, etc. do you have? What are your current goals that pertain to diabetes or chronic disease, care, treatment, and prevention? What diabetes program do you already offer? What resources do you have to support care in your community? Identify key partnerships to support diabetes care in your community. So what partnerships already exist and what partnerships need to be established? We are currently sending out like a call to action for people to join our diabetes coalition. And so this will really help for steering our program and to really recruit community members that are struggling or are really achieving success with diabetic management. And these diabetes champions are so important for overall programming and can be great facilitators in those support groups. So we really need to be mindful that we are not duplicating services, but maximizing referrals and facilitating program expansion. We must be committed to work within the health care systems as a whole to coordinate planning and referral efforts, connect individuals to community resources, and determine ways in which to follow up to support and encourage follow-through. And community members must be willing to participate in to provide feedback for and become advocates in all levels of program planning and evaluation. Increasing patient access to care and community resources through meaningful connections with relevant community partners through a system-based socio-ecological approach fosters behavior change at multiple levels of influence to effectively reduce the disconnect between healthcare and public health organizations, and is an economical way to provide instrumental treatment and screening services and encourage participation in programming that ultimately reduces the incidence of diabetes and development of complications of diabetes in our service areas. And so with that, I end my presentation and am happy to take questions.
Rachel, we've had a few questions, and I can read them for you, and you can respond, or if you want to read them and respond, either way works. Do you see the questions there?
I do, and I'm happy to go ahead and read them. So what is the average length of comprehensive visits, and what does pre-planning look like? And so my average length of comprehensive visits is an hour to an hour and a half for the initial assessment, and then can range from 15 minutes to up to an hour dependent on the patient's needs. And so within our team, we're working with a dietitian, a diabetes educator, and a clinical pharmacist. And so it really is tailored to each person's needs. And sometimes we all three see that patient for short visits. Once in a while, we'll see them together if that's needed. We plan to do our initial assessments together, just so when we're enrolling people into the specific Good Medicine program, that's what we'll be doing. And so it really varies, but that first assessment is taking an hour to an hour and a half. And so sometimes it's really important because those visits sometimes need to start with building that relationship and getting answers. So sometimes I've noticed that actually spills into the second visit, and sometimes I get some more information during that second visit that's related to the assessment piece. And the pre-planning visits, I like to scrub through the chart, know what they're going to be needing. So out of the primary care team, I'm talking, and look, do they need a foot exam? Do they need a dental exam? Do they need JVN? And then how can I connect them with my partners? And really making sure that they've had their labs, that all of the information is in there. So if they haven't had labs for a while, they haven't been in to see their primary care team, that pre-planning visit includes going to the primary care team and having them order the labs, maybe do a quick telehealth visit with the patient if they haven't been in for a while, and then schedule an appointment when they're coming in if they need to. We've done actually a lot of telehealth. I know, so I always look for the silver lining in things, and COVID, with that silver lining, would be that expansion of telehealth. For us, really being able to reach out to individuals in their homes instead of having to travel to a remote site, because sometimes in Montana, even though it's not as far as where they would be being seen, traveling to a site for that telehealth visit can still be 100 miles or more away. And so those telehealth visits has really been helpful for us. So our diabetes team, we're currently building our diabetes team. We work within that primary care team. We have 3 clinical pharmacists, a diabetic educator, a registered dietitian nutritionist, a care coordinator and a case manager, and we're working on those positions right now. A health tech to go, or a diabetes paraprofessional, 2 of those, and then 2 patient navigator or resource kind of specialists that kind of keep patients on track. And some of those roles we're developing. We just received that SDPI grant in December, and so it's a new program for us, and so we've really incorporated that into our Diabetic Center of Excellence. You definitely don't have to have that big of a team. For a while, it was just the diabetic educator. It's just getting everybody else on board. And so for all your health techs and nursing, they have the diabetes paraprofessional courses through the ADA, which I would recommend individuals taking, just so they can have, like I said, those meaningful conversations with patients. And they can help move along that stages of readiness to change. I know sometimes we try to give meaningful advice, but we don't know, and so just those diabetic basics that are taught in those diabetes paraprofessional courses, I think, are great. And then having some meetings and training, keeping everybody on the same page, that consistent messaging is really important. And so I think all of our healthcare staff, with such a large incidence of diabetes, especially in our populations we serve, that education and training is so important. So what do DM huddles look like? Does that include providers? And so yes, so in our facility, we have team rooms, and there's 4 people in each team room. And so they have their provider, their nurse coordinator, case manager, and then their health tech. And so it involves, in the PCMH model, that huddle involves everyone, including pharmacy, the diabetic educator, and the nutritionist. And so those meetings don't have to take very long. They can be 15 minutes. We usually scrub the chart beforehand. We look at, could we use a warm handoff? Has this patient missed appointments lately? Sometimes we have a high no-show rate. Let's check in during a warm handoff, just see where the patient's at. If we can reschedule, how can we remove the barrier to them coming in? we look at different medications. Could it be, I don't like the compliance issue, but what barriers can we remove for that patient? And sometimes that is barriers to taking medications or monitoring blood glucose. So they take about 15 minutes. We have 3 primary care teams here. And so we just stop in and, like I said, 10 to 15 minutes, just like a really quick overview saying, hey, do I need you? Do I need your help? Does this patient need a referral? So on and so forth. So does a hospital or clinic have to be accredited program by the AADE in order to bill for teaching blood sugar machines and insulin teaching? And so some of that can go through pharmacy or the nurse educator, so they can be billed as a nurse visit. But if you're looking at it under the guise of charging or coding it out as diabetes self-management education support or training, you do have to be accredited. And so they have accrediting programs through ADA and the AADE, but it's ADE-SES now, I believe. And so they have great accrediting programs through those. And so our blood sugar machines also have been, that education can be billed out through public health. Also, we have a public health department on staff, and so they've done the billing for that. But if you're coding it as DSMES, then it really does you need to be accredited. So does anyone incorporate electronic and multidisciplinary flow sheets in the electronic health record, similar to DMS tab, but title more information with a place for centralized goals and follow-up? Just curious. So we are right now working on something like that, especially since we're all coordinating the care and not wanting to provide the same type of training but augment what the other professional has educated the patient on and support. The other thing we're working on in the EHR is a whole referral process. Instead of just referring to 3 different entities for diabetes care, it'll be the Diabetes Center of Excellence or Good Medicine referral, and we'll have dietitian, diabetic educator, and the pharmacist, the clinical pharmacist on there. And so we'll all 3 receive that, and then we'll enroll the patient into the program. But as for the flow sheet, I have not found that yet. We are really looking on developing that. For us, we have a lot of great information that kind of pulls into our diabetes report card. And so we use that, but we're looking at ways to enhance how we use that also for a better flow. So that is my answer for that. If anybody wants to type in if they have electronic or multidisciplinary flow sheets that are available in the electronic health record, I would love to know about that.
Thank you, Rachel. I think you made it through all of the questions. Looks like maybe a couple. Oh, we just heard from your own service unit. Pro service unit has a DEAP accredited program.
Yep,
anyway.
That's where we are accredited, and so that is through the ADECES, so the former AADE. So how do you flag follow-up appointments or lost follow-up appointments? We have our appointment desk scheduling help with that. We're in different processes. For me, I keep a log of patients that didn't come or we need to follow up with. And part of that's that team huddles. When we're looking, we can look, when we're scrubbing the chart, we can look at when was the last time they were in? Have they missed any appointments? Do we need that warm handoff today? Just to touch base to see when they would like to reschedule or remove barriers to maybe why they haven't had the chance to come in. Can we provide some quick education right after their appointment? And so I think it's kind of individualized, but that's right now I don't have a way to do that within EHR, so I kind of keep manual track of that.
I